The prostate is an organ found in men that helps produce semen. It sits behind the penis, underneath the bladder, and in front of the rectum, and is about the size and shape of a walnut. When cancer forms in the prostate, it often grows slowly, especially in older men. In fact, 1 in 6 men will get prostate cancer, but most will not die from it. Still, prostate cancer kills 30,000 men a year in the US and is an often misunderstood disease and challenging to diagnose and treat.
Among the cancers that exist in humans, it probably has one of the broadest scopes, from harmless essentially to lethal.
Prostate cancer is a more difficult site to treat than many others, in part because it's hard for us to know which ones are the important cancers to treat. In a way, it makes it a lot more difficult that people do so well, because a lot of times if a patient has a low-risk prostate cancer, they can do very well for many years before they develop any symptoms or signs of the prostate cancer.
This is why most doctors agree that screening is important. Screening is recommended for all men over the age of 50. African American men and men with a strong family history of cancer are at higher risk and should be screened earlier.
Currently what we have is a physical exam, which is a rectal exam, to feel the prostate and ascertain whether there are nodules or firmness, areas that are suspicious for cancer. The second thing that the internist or urologist may get is a blood test called PSA to see if an elevation in that blood test is suspicious for cancer.
If a man either has a nodule on his prostate or an elevated PSA, he will go on for an ultrasound-guided biopsy of the prostate.
These tests are usually performed in a urologist's office and are an outpatient procedure that takes about 30 minutes and involves mild sedation.
The ultrasound is a probe that's inserted into the rectum, and through that probe there's a needle guide so that when an area is identified of the prostate, a needle is inserted into the prostate and a biopsy is obtained from that area.
Good specimen.
The problem with ultrasound, though, is that it really doesn't detect cancers. It simply shows you where the prostate gland is. That allows you to direct biopsies into the prostate somewhere, but not necessarily into the cancer.
Doctors take several samples of the prostate tissue, usually 12, in what is called a multi-core biopsy. Because doctors are not able to clearly target specific areas of suspicion, it's often called a blind biopsy and may miss the cancer, possibly giving a false negative. This is a big challenge in accurately diagnosing this disease. New techniques are being developed using magnetic resonance imaging, or MRI, which allows doctors to see potential cancer more clearly to guide biopsies in the prostate. Doctors can perform a real-time MR-guided biopsy, or with new software, they can fuse previously obtained MRI data with a real-time ultrasound to guide the biopsy needle into the specific areas of suspicion. These procedures will hopefully result in more accurate diagnoses in the future. From the biopsy, pathologists will determine if the samples taken are cancerous, and if so, doctors will grade how aggressive the cancer is, using a system called the Gleason score. Then they will stage the cancer.
When the tumor is completely confined to the gland, that's a low-stage tumor. But there's a question if the prostate cancer has come outside the capsule of the prostate. So commonly what's done for that is an MRI, typically an endorectal coil MRI.
Doctors will then use a variety of imaging, like CT scans and bone scans, to see if the cancer has spread, and to help decide the best treatment options and plan for the treatment.